right, just look over our attendees. We're on to several pages now, so I think we can probably get going. So good morning, everyone, and welcome. It is my pleasure to introduce our speaker this morning, Dr. Austin Anthony, who is one of our BNI residents. He's been with us since July, so this is wrapping up his time here at Phoenix Children's. Dr. Anthony did his undergraduate schooling at Vanderbilt and then went on to the University of Pittsburgh for medical school. And it has been a pleasure to have him here with us for this rotation. And as you can see today, he is talking about a topic that is near, though not necessarily dear to our hearts, and that looks like preemie IVH. So, all right, Austin, take it away.
Awesome. Thanks for that intro. So yeah, today I'll be talking about the emerging investigation towards the management of these kiddos with preemie IVH. Okay. So hopefully by the end of this talk, we can discuss the current neurosurgical management strategies for these kids, as well as review the literature on how the timing for these interventions impacts their outcomes. So why do we care? So preterm infants, b born before 37 weeks are at a high risk for this pathology. 15% of infants under 1.5 kilograms develop IVH. And then from these kids, post-hemorrhagic hydrocephalus occurs in about another 20%. And then from these kids, about 10 to 20% of them will require permanent shunts. So how is this happening? It's thought that, these premature kids have fragile germinal matrix vasculature. The choroidal vasculature is the dominant supply of blood to these kids before the larger vessels develop, and it's thought that there's impaired autoregulation of this blood flow, which can lead to venous stasis and ischemia, and thus IVH secondary to that. So this matters because during this time between 24 to 40 weeks gestation, they're at a high risk and very susceptible to these injuries. These oxidative and inflammatory injuries can have long-term effects on them, and that's thought to be because of microglia, which can impair neuronal maturation as well as be toxic. So the risk of cerebral palsy, epilepsy, and cognitive delays in these kids is very high. And the severity of IVH has been shown to predict their outcomes. So basically, this slide just boils down to the causes of IVH. It's really, you can trace it back to either venous stasis or ischemia that basically cause it. And these are all of the like different ways you can see that manifest. So there are some things that we do to prevent it, obviously. We give patients corticosteroids. This decreases the risk of ARDS, thus decreasing the risk of like high venous stasis and thus IVH secondary to that, as well as indomethacin, which can decrease the risk of PDAs, which also downstream decreases the risk of IVH. So IVH without hydrocephalus still affects the brain. Blood is obviously not supposed to be in the CSF spaces. And the iron in the blood creates these reactive oxygen species, which are toxic and can cause neuronal injury. And it's been shown in animal models that you can provide some neuroprotection with agents such as like stem cells, but that's not really applicable to us. And then as far as the pathophysiology of why babies with IVH develop hydrocephalus secondary to that, it's secondary to the obstruction and impaired CSF reabsorption by the blood. The blood is not supposed to be in these spaces. It can cause fibrosis of the arachnoid villi, which is what reabsorbs this. And it also is thought to be mediated by TGF beta 2 and VEGF, which increase matrix deposition, thus decreasing CSF reabsorption. Um, and then this increased pressure can cause compression and ischemia, which can cause white matter injury secondary to that. So if your kid just has IVH, the effects of that, I mean, just hydrocephalus, the effects of that without the effects of the actual blood is, like we just said earlier, is that mechanical injury, that increased pressure But that increased pressure can also cause increased inflammatory activation of microglia, which can also uh, cause some neuronal injury. There have been some studies that show early shunting allows recovery, but late shunting does not, and that's thought to be because of that increased pressure injury. So when you combine these entities, you have your IVH as well as your hydro. That is thought to cause by iron and blood in the CSF, which can worsen. It's both that toxic and that pressure, which can worsen injury, and that leads to impaired myelination, cortical injury, and uh, things secondary to that. So. Uh, Not every kid with this condition will need like permanent shunting. It's been shown to stabilize or regress in 65% of kids. And then in low grade IVH, so grades twos and threes, these kids very rarely actually even need any sort of intervention. However, in 30 to 35% of these kids, it does progress rapidly, and then we do need to become involved. And there currently isn't like a universal agreement on when to intervene. So that's what we're going to talk about today. So, what are the presentation patterns of these kids? So, usually we're called after, there's notice some increasing head circumference. The fontanelle, is more bulging, and then you also have suture swelling. And then things that concern us on exam are if there's apnea, bradycardia, or lethargy. They can't be explained by other causes. So usually the first imaging modality we get on these kids is ultrasound. This is nice because you can do it at the bedside. If the kid is really unstable, you don't have to worry about transporting them for MRI. You don't have to worry about sedation as well. And then usually we combine this ultrasound with, the history, the exam, and the story to determine like what needs to be done next. So these kids with IVH usually they're at high risk for other structural abnormalities, obviously. And cranial ultrasound isn't the best tool. It's usually the easiest, but a lot of times before we would actually intervene, we'd have to get an MRI if they're stable enough to be transported. And one of the key measurements we use on the MRI is the frontal occipital horn ratio. This is calculated by adding the length of the frontal horn, I mean the width, as well as the width of the occipital horn, and then over twice the biparietal diameter. Normally in kids, it's about 0.36. However, in a lot of the studies, the cutoff is about 0.55 that they use for considering intervention. So the question to intervene or not uh, basically it boils down to your clinical findings and then your serial imaging. It's usually done with ultrasound, and then that helps you distinguish whether the hydrocephalus is symptomatic or if it could just be like ex vacuo. And the clinical signs that you want to look for are apnea, bradycardia, and bulging fontanelles, as well as trending increase in head circumference. So one of the studies that sought to make a more universal protocol for this was the SOAP study. There was, there still is, there's like a lot of bias in local practices of like what they consider, bradycardia, what they consider splayed sutures. So this study sought to standardize the rubrics and treatments for these conditions. So they define bradycardia as three or more episodes in 24 hours that can't be explained by anything else. They called splayed sutures if it was over 2 millimeters. A bulging fontanelle was defined as if it was above the level of the surrounding bone. And then they also defined extrachoroidal IVHs over 2 centimeters volume wise. And then the abdomen, basically most people agree on this, any inhospitable abdomen if it has necroenterocolitis, there's or some other condition that prevents shunt placement. So the way this study worked, it was multi-center, and it basically included any preemie that was over 1.5 grams had a grade either 3 to 4 IVH and was expected to live longer than 72 hours. If they thought the kid was going to die sooner than that from uh, a non-hydrocephalus cause, they obviously were not included. And it basically broke down the decision trees for these kids as to whether to treat or not, and if you were going to treat them, whether you would put a permanent surgical solution, which would be a shunt, versus a temporary surgical solution, which would either be a reservoir or a subgaleal shunt. It randomized into the reservoir versus the subgaleal shunt just to see if there was any superiority between the two. So we'll go through the treatment decisions now. So st patients in the study were over 1.5 grams. They had either grade 3 to 4 IVH, and they're expected to live longer than 72 hours. If their frontal-occipital horn ratio was over 0.5, then they would make it into the study. So if it was over 0.55 and they had bradycardia and splayed, they basically had two of the three criteria that we talked about earlier, then it would be considered you would treat. If not, then you would just observe. So once they decided that the patient needed to be treated, you want to know, are we going to put a shunt in or are we going to put a temporary treatment in? So if they had, any sort of infection, then they would usually go for ventricular taps, or like try to treat the infection. If they had extrachoroidal IVH, basically you're gonna temporize. They didn't want to shunt kids with extrachoroidal IVH, or if the abdomen was not usable, they would also temporize. Now, if the patient's weight was under 1.8, they would go ahead and temporize as well. If it was over 2 kilograms, they would just go ahead and shunt. And then if it was in this gray zone between 1.8 and 2 kilograms, then it was up to the surgeon what they wanted to do. Uh, and then patients that got reservoirs or considered to get reservoirs were patients that frontal occipital horn ratio was over 0.5. And they did have extrachoroidal IVH, then they would, continue the taps. If the abdomen was not usable, then obviously they would continue the taps. But if the abdomen was usable, and they didn't have extrachoroidal IVH, and they were basically over 2 kilograms, they would go ahead and place the shunt. If they were under 1.8, they would continue tapping until they got into that 1.8 to 2 kilogram range, and then it would be up to the surgeon what they wanted to do. Kind of a similar decision tree for the subgaleal shunts. If they basically met the criteria for subgaleal shunts, but they had extrachoroidal IVH, they would continue the subgaleal shunts. If the abdomen was not usable, they would continue subgaleal shunts. However, if the weight was over 2 kilograms, then they would consider shunting. Otherwise, it's the surgeon's preference if it's above 1.8, and then if it's less than 1.8, they would continue the subgaleal shunt. So we just talked about these two different modalities. There's the ventricular reservoir and the subgaleal shunt. These are both temporary surgical options. And as we just spoke about in the decision tree, the goal for these options is to delay until VP shunt if the patient needs it, or to just temporize until they don't need any treatment. So the difference between reservoir is this is, as you can see here, this is a system that goes into the ventricular system and then has a reservoir that you would drain the CSF by tapping, versus a subgaleal shunt, which is more of a continuous drainage system that drains the CSF into the subgaleal space and creates a pocket. So the basically the difference workflows is with a ventricular reservoir, you have to actually tap the uh, system continuously to actually get things out of it. You have a little bit more control over, how much you won't tap because you're taking it out. However, it does require more effort on the part of the team because you have to actively tap it. A nice thing is you can send these for studies. Obviously, with the ventriculocerebral system, this is a closed system. While it is continuous, so it works automatically, it is a closed system, so it's a little bit more difficult to send your fluid for studies if you are concerned about that. There's no previous studies basically show there's no superiority between the two. They have similar complication rates as far as infection, obstruction, and revision rates. So it's really up to the surgeon which option they want to choose. So back to the SOAP study, it was 145 patients were enrolled, and 102 of them received temporary um, treatment. This is basically just showing the patients had similar sex, race, grades, and ventricular size. And then there were a little bit of differences in the gestational age and birth weights, but they controlled for these in the analyses. So the primary outcomes of this study were conversion to permanent shunt within 6 months. And then the secondary outcomes that they were looking at were the complication rates between the two different temporary modalities. They also wanted to look at neurodevelopment outcomes in the long term. So as far as the permanent surgical options, we discussed earlier, that's the VP shunt. That's the mainstay. Obviously, in our decision tree, we discussed how you want to delay this until the patient is over 1.8 kilograms and also infection free. There are high revision rates with this procedure. It's considered to you have about a 50% chance of revision within the first 2 years. And there's also concern for infection, but we've taken steps to mitigate this through use of antibiotic impregnated captors and also standardized infection reduction protocols. Um, there have been studies that have showed that multiple shunt revisions does worsen the prognosis of patients as well. Alternatives to shunting are ETV, CPC. There's limited data on this. There have been a few studies that have shown that there's a low success in this patient population. Patients with IVH and young age are not considered to be the best patient population for success with ETV and CPC, but this is also still under investigation. So back to the SOAP study. Um, Basically, it showed that whether you put a subgaleal shunt or reservoir in these patients, you basically have the likelihood that you would need to convert to a shunt is about the same. So there's no superiority between these two modalities. It also showed that the complication rates were about the same as far as infection, CSF leak, and mortality. There's no difference between the groups. So it's really a surgeon preference um, what you want to use as your temporary measure. Some of the advantages of the reservoir, you control, you can actually control exactly how much CSF you want out. You can send the CSF for studies a lot easier. And it's, you're taking the blood out of the system. So it's considered to have potential reduction in blood burden as well. There's also a theoretical benefit of being able to do outpatient tapping. However, most of these patients, if they need this, they're usually too sick to leave the NICU. Um, some of the cons is because you're poking the skin, there's a risk of skin breakdown and CSF leakage. And then also there's a higher burden on the team as it requires repeated tapping, and it's not just a continuous system. So some of the reasons people like the subgaleal shunt, it's a closed system. Because the fluid is being reabsorbed by the body, there's less of a risk for electrolyte loss. Um, and but some of the cons are, this puts a pretty big pocket on the kids' heads. So um, cosmetically, a lot of people kind of shy away from it. So the conclusion of this study, both of these treatment modalities, while they're, different, they have similar outcomes. There's no difference in whether kids get either, whether they'll need a shunt or not. complication rates are comparable. So it's really up to the surgeon which one of these methods they want to use. So next we'll talk about a different study. This is the drift study. This sought to determine, drift stands for drainage, irrigation, fibrinolytic therapy. So uh, in this study, they injected fibrinolytic therapy followed by a CSF lavage in patients to determine whether, you know, could we use these clot busting agents and then wash out these CSF spaces? Would that, improve these patients' outcomes? So it's kind of a cumbersome study. It would involve inserting two catheters in the brain to administer this intrathecal clot busting agents and then also lavaging the system out in order to clear that blood. So that, yeah, their aim was to remove blood, and they thought that would reduce the pressure and inflammation and thus reduce the need for shunts in these kids. So it was a randomized control trial. It was multi-center, and they basically randomized kids to drift versus standard of care. And then at 2 years, they looked at severe disability and death. They also did a follow-up study that looked at these patients 10 years later, and they examined their cognitive quotient to see if this study had long-term benefits for these patients. So the 10 years follow-up study had 77 patients, and they examined their long-term benefits as well. So driftile ventricular drainage irrigation, and then they used TPA in order to bust these clots. They found that there was no reduction in the permanent shunt needed, and the trial was actually stopped early because there was a possible increased risk of secondary hemorrhage, thought to be because of the administration of the TPA. So they have considered some modified approaches, which is just doing the ventricular lavage without the administration of TPA. However, there's some debate over this because the thought is that TPA reduces the blood products as that's necessary for this intervention. So in the 10-year follow-up, the cognitive quotients of the drift kids were actually higher than the standard kids. And of the surviving children, the drift kids actually had less likely to have severe cognitive disabilities than the standard kids. So this graph just shows you that there was a significant difference in the drift kids' cognitive quotients at 10 years compared to the kids that received standard of care. They also looked at some secondary outcomes, vision, sensory motor disability. Uh, they found that the kids had similar rates of CP. However, there were trending towards having better vision. Sensory motor, they weren't able to find any difference as well as in the behavioral tests. So the strengths of this study, they had long-term follow-up, over 10 years. It was blinded. It was done in the UK, so they were able to have, high retention rates. Limitations, it was small. The groups were not perfectly balanced at baseline. And the concern with this study is it's pretty invasive. It requires two EVD catheters. It requires, release or administration of a potentially dangerous medication. So it's very complex and can't be generalized to non-tertiary centers. And also, the study was terminated early due to increased risk of secondary hemorrhage, thought to be because of the TPA. So while the study did show that it improves, some cognition at 10 years, so that it was staying sustained, it didn't significantly improve motor outcomes. There were trends that it could be better for visual outcomes, but they weren't able to actually have the study powered for this. So, so proof of principle, it does show that secondary brain injury can be reduced by CSF lavage. There's no reduction, however, in whether these kids would need a permanent shunt, and there's increased risk for secondary hemorrhage. So people have considered a modified approach as to whether you could just do the lavage without the TPA, but there still needs to be a few more studies on that. So while it is promising, it still, requires further evaluation because basically what it boils down to is the kids that did survive from this study did better. However, there's increased risk of injury. So it's a risky thing. It's like if you do not have any increase, if you do not have a secondary hemorrhage, you'll do better than kids that weren't enrolled. However, if you are enrolled, then your risk of having a secondary hemorrhage is increased from standard of care. So that's why this even though this has shown that it could have long-term benefits, that it hasn't been widely adopted. Uh, in addition, it also requires highly specialized centers due to technical demands, which is also kind of kept it from being adopted widely. And there was also stigma because it was terminated early. So another trial that uh, sought to determine, optimal times for intervention was the Elvis trial. So this looked at early versus late intervention in these kids. So, we talked about earlier, we talked about, when to intervene, and we talked about the drift trial, but the concern now is like, what is the optimal timing for intervening? So like, there wasn't a very clear early versus late threshold. So this trial sought to, determine whether if you intervene early versus late, would there be any difference in outcomes in these kiddos? So there was some preliminary data that showed that early drainage would improve ventricular size and injury markers. They're wondering if this would, um, so that was like the motivation behind this trial. So this trial used some different key measurements than the SOAP trial that used the frontal-occipital horn ratio. This trial used the Levine index, which you can see here. And basically, their interventions for threshold were at the 97th percentile, which is determined based off the gestational age. And then they added 4 millimeters, which would be the higher end for the late intervention. And then the anterior horn width, this um, they also used this measurement, and they basically said over 6 millimeters was abnormal. Another score that they used in this study is actually the Kadokoro score. And basically, this is just a score of how many abnormalities your MRI has. And basically, each abnormality gives you a point. So the more abnormal your MRI looks, they're wondering if that had any bearing on your outcome. So this was another multi-center study, and they randomized patients into the low threshold, which would be a VI of 97% or anterior horn width of over 6 millimeters. And then they added 4 millimeters to both of these measurements, which would be considered the high threshold, which would be a VI of over 97% plus 4 millimeters or anterior horn width of over 10 millimeters. And the interventions were serial LPs or ventricular reservoir tabs. So this study looked at outcomes at 24 months, and they assessed the cognitive and motor abilities with the Bailey scores. So as we said, it's 113 infants, and they were comparable groups at baselines as well. So the primary outcomes, basically, first, if we're looking at the Kadokoro score, which we spoke about earlier, which is basically a measurement of the abnormalities on your MRI, it determined that, or it showed that, you're more likely to have an adverse outcome if you have more abnormalities on your MRI. I mean, that makes sense. And then this is the ventricular measurement zones that they used in this score. You can see the anterior horn width graph is flat, it does not matter about the gestational age in that one. However, as you see, the VI it increases. That's why it's the considered 97% plus for 4 millimeters as your as the different um, interventions. So, as far as the Bailey scores, the low intervention threshold did have a absolute value of a higher mean score. However, they weren't able to actually find any significance between these. There was a trend towards significance as far as motor comes, and also the frontal occipital horn ratio was also trending, was also lower and more favorable outcomes, but there wasn't a significant difference between these groups. Now, interestingly, they found that as far as patients that received VP shunts, that the low threshold patients had similar outcomes to the patients that had not needed a VP shunt. And the higher threshold patients had worse outcomes than the patients that than the worse outcomes patients that had not needed a VP shunt, which kind of suggests that intervening early would have better outcomes for these patients. So uh, the key findings here are early intervention, can reduce risk of death and severe disability. However, early treatment was also linked with smaller ventricles and less injury. Um, and the impact of shunt was worse if the intervention was delayed. So if they got the shunt early, the kids did better than if they got the shunt late. So this study basically suggested that early intervention may improve the outcomes in these kids. It supports monitoring and timely management strategies so that you can intervene early. However, long-term follow-up study is needed as well. So, why? So basically, with this study, the question is like, why is this not widely adopted? One of the things is this only showed a trend towards improved neurocognition in 2 years. Uh, People have not actually been able to replicate this study. So while it does suggest that earlier intervention may help, it's hard to generalize this study. It was also underpowered, so we need more studies in this space in order to determine what the actual optimal threshold is. So there is some data that suggests early intervention may help, but it's not strong enough to actually implement worldwide, as we haven't been able to replicate these studies. So I'll just end with a quick study that talked about, predictive factors for shunt dependency. So this was a retrospective study. It was one center, so it is not as high powered as the trials we spoke about earlier. But basically, they wanted to see if there was any predictive factors in kids with neonatal IVH who had EVDs, and then they would challenge them for a shunt and see if there were any things that they could tell or any predictive factors that basically would mean they need a shunt. Just, it's interesting because, when we have these kids and we're counseling them on, whether we think they'll need a shunt. It's nice to be able to, that certain characteristics of their pathology will likely mean that they need a shunt. So, what they collected in this retrospective review is, age, sex, comorbidities, GCS on admission, the location of the bleed, as well as the modified Graves score, which is basically just a score of like where the blood, it's a score of like where the blood is in different parts of the brain. They also used urokinase, so kind of similar to the drift trial to see if using that would reduce the need for permanent shunt. So they basically EVD challenged these patients, and would say a shunt was indicated if the ventricles enlarged on the challenge or if they had ICP sustained above 20. So shunt was required in 26% of these patients. Uh, they were more likely to need a shunt if they had a worse GCS, which makes sense. If the ICH was actually thalamic, if they had a higher MGRAB score, or if they had a higher bicaudate index. So the key predictors were the MGRAB score, the bicaudate index, and and whether the ICH was thalamic. Interestingly, the volume of the bleed was actually not significant. However, the location was a strong predictor. Um, Interestingly, as well, unlike the drift trial, they weren't actually able to show any or like the drift trial, they showed that the use of urokinase did not significantly change whether these kids would need a shunt or not. Obviously, limitations of this is retrospective single center, is small sample size, and they actually did not have a standardized EVD protocol as this was a retrospective study. So just to wrap up, as far as predictors for whether kids will need a shunt or not, this study suggests that, radiographic severity using these scores, as well as clinical predictors, which is low GCS, and location matter. We think about this a lot too when we see kids come in with a low GCS um, or like, blood that's distributed in a large parts of their brain, which would give them a higher grab score, that they're more likely to need a shunt. So we kind of already use these to counsel families, but it was nice to read a paper where they uh, analyze the data. So that pretty much wraps up my talk. Happy to answer any questions.
Yeah, hi, Austin. It's Jay Houtman. That's a great overview of, I think, several of the most influential neurosurgical publications regarding the management of preemie IVH of the last decade or so. I have some comments, but I'm going to hold them off just for a second and poll the audience here, because I know there's several people in attendance who have thoughts on this. I mean, I think this is a good opportunity to kind of explore what people's positions are on, neonatal shuntology, both from a neurology and a neurosurgery perspective. Uh, what? Let's open the floor. I know Dr. Friedman, you probably have some thoughts. Tara Mangum, you may have some thoughts. Kara Lewis, you may have some thoughts. Why don't we let's chat about this? I think it's a really good opportunity to explore this a little bit. I don't know who's on. I just named a couple people, but I'm not actually looking to see who's on the rounds today.
Yeah, Jay, Neil's away this week, and I think Kara's out too.
Okay. Well, then maybe the neurosurgeons, we can have a discussion. I mean, here's the thing. So here's my perspective on the landscape, and I'd love to hear people's opinions on this. It all boils down to what the institutional bend is towards shunting neonates. In other words, there are many institutions where the overwhelming desire is to not shunt, to do everything you can to avoid shunting a preemie IVH neonate. Well, why do we have that opinion? One is a lot of us are trained that way, 20, 30 years worth of neurosurgical training. Two is that all the literature that we have regarding shunts and preemie IVH is that they are more likely to need revisions. They are more likely to be complicated. These are kids that get loculated hydrocephalus. These are kids that need, on average, more revisions over their lifetime. One of the clearest predictors of shunt failure is age at insertion. And so these are the youngest kids that we insert shunts into and therefore have the highest likelihood of needing revision. If the institutional bias is to not shunt these kids, then really you're just going to adopt protocols that just push you if the head is blowing up, if the fontanelle is full, if there are signs or symptoms of CP. The thing about the drift trial, the Elvis trial, not the SOF, because I actually think the SOF is the best attempt we have at standardizing criteria for intervention across a multitude of national centers. But like drift and Elvis, what they are really suggesting is, do institutions want to adopt protocols that ask for earlier intervention, may result in more shunted patients, but could perhaps improve neurocognitive outcomes. And I think that that's a huge ask of neurosurgeons everywhere, to really push the needle towards, you're probably going to end up shunting more kids, you're probably going to end up revising more shunts, but maybe you will improve neurocognitive outcomes. And I think that's actually the greatest barrier to adoption of early intervention in preemie IVH, is that most neurosurgeons don't want to end up with more shunted preemie IVH, which is exactly what will happen if we start intervening earlier. We're going to intervene on kids that we wouldn't have before. I'll stop there. That's sort of my take on the landscape, and I'd love to hear if people have other thoughts.
Yeah, Jay, I would just say I think we deal with what's in front of us to some degree, right? And so when we're looking at a baby who seems to be hanging in there and doing okay with bigger ventricles, we're not thinking so much about what does every day that goes by with these ventricles do to them 10 years from now. We're thinking about right now, they don't have an infection, they don't have a CSF leak. Let's keep the status quo until we really feel we're pushed to do something. And so I think until we have more concrete data that long-term outcome is really going to be impacted, as you say, it is hard to move the needle on intervention now. So that's just sort of my take on it.
I mean, Ruth, I think you're 100% right. I think the Elvis needs to be repeated in North America. I think that just needs to happen. For American neurosurgeons to adopt it, we need to see it ourselves. And I think that's going to happen. The HCRN is now looking at putting together a U grant for exactly this, and will probably be a site, hopefully, if that were to get funded. And the drift trial, unfortunately, will probably never get repeated because it's a logistical nightmare. I mean, could you imagine just lavaging the ventricles in our NICU? Could you imagine the volume of phone calls that we would get? Could you imagine the traveler nurses managing bilateral EVDs? I mean, it's just never going to happen. And so I don't think we're ever going to get a repeat out of the drift trial. I think that it would have to be a very, very special place. And to be honest, it would have to be very, very special neurosurgeons that would be willing to subject themselves to doing that trial. But I think the Elvis there might be a shot that would get repeated in North America, and maybe that would address exactly what you're talking about, which is, in order for us to be willing to, pull the trigger on long-term outcomes, it just needs to be a little more convincing. I'm not totally convinced by the Elvis trial. I think the problem with Elvis is that the earlier you intervene, you're going to be intervening on a subset of kids that would have never been intervened on in the first place based on soft criteria. So you're over treating, and that's always going to leverage your outcomes if the groups aren't completely balanced, because that means that there was some subset of kids that would have been fine regardless, that would have had better neurocognitive outcomes regardless, and that would move the weighted average of that group a little bit better. Peter, Jenny, Dave, you guys got thoughts?
Yeah, Jay, very good kind of synopsis on just the national tone surrounding a lot of this thought process. I mean, I think that the Elvis trial created a lot of neurosurgical dyspepsia across the country, largely because, it raised a lot of eyebrows. It was very intriguing, and it made us all, think, I wonder how I might be doing things in the future. I don't personally know anyone who has directly changed their practice as a result of Elvis, but certainly it's caused us to think about things. And I very much agree with HCRN hosting the pre-IVH trial, which is what they're planning to do eventually. I think that if we have something to support a change in practice, and that's really important, I think that neurosurgeons in the United States would do that. But on the other side of the coin, it's important not to throw the baby out with the bathwater, because once we start doing things very different, there are going to be unanticipated consequences of that, including what you had mentioned, which is more kids might get shunted, potentially unnecessary shunts would be placed, and more that we can't really even envision at this point. But I think it's important to be talking about this literature. It definitely holds an important place in terms of what we're thinking about next and where we might go as a field potentially, but not for certain. In my mind, the importance of SOF was SOF has essentially become part of our sort of common lexicon or our thought process about the way that things can be done. I don't think that SOF necessarily had a huge impact on national neurosurgical culture with regard to its results, but really more its protocol. Essentially, the protocol was a PR campaign for saying, here's one option for how to do it. I think that neurosurgeons across the country have a wide differences in local and historical practice with regard to shunt timing in low birth weight babies, and that's okay. It's normal to have quite a bit of variation in this, and so essentially just set a point somewhere what they had considered to be the middle, and it allows us to kind of base our criteria in comparison to SOF, even if we don't agree or practice identically to the use of the SOF criteria. It just gives you a useful starting point that has been vetted in a certain way and kind of accepted in a number of pediatric subspecialty centers. So that's my 2 cents on the matter, but happy to contribute answers or thoughts.
Yeah, Peter, I agree with everything you said. I think the SOF is exactly that. It's a common denominator. It's a common language. It's a rubric that's accepted, has been vetted, to use your word. I totally agree. The other thing I would say is that for our neurology colleagues in the audience, the part of this that you don't see is the back end, which is the shunt management long-term over the lifetime of the child of preemie IVH. We consider preemie IVH the worst of the worst. These are the children with the most challenging shunt outcomes. And so when Peter mentioned, sort of the possibility of us over shunting these preemie IVH kids, that could have a massive back end impact on the long-term management of these kids throughout their childhood. Because like I was saying earlier, everything we know prospectively about the need for revision suggests that those kids are going to need the most revisions over their life compared to other shunted children. And so that's where that sort of neurosurgical dyspepsia, I think, comes from. Jenny, Dave, any thoughts?
I don't disagree with anything I've heard thus far. I think that just because over the years, the paucity of data that we've had, it has led to people just, I think, doing what feels right to them, for lack of a better word. It's the gestalt that you feel when you just look at a kid, you look at a family, you feel them out, you get a tone as to what the feeling is among the NICU staff, which has changed significantly over the years at this institution. And I think, none of us are going to disagree with it when you've got a baby whose vents have blown up on serial ultrasounds and it feels tight that they need intervention. Um, and I think that very few of us have had any overt hesitancy to putting in a temporizing device. I think for me, at least, the biggest question is, when do you pull the trigger, converting that to a long-term permanent device? And, we've all had kids that the parents have been reluctant to shunt. You've tapped them for a fairly extended period beyond what your colleagues might do. And ultimately, the kids have seemed not to require a shunt. They've kind of stabilized. And then that kind of influences your thinking for the next kid. So I think it's become one of these things where, without terrific, convincing data on long-term outcomes, which I think is always problematic, um, people are going to still kind of do what feels right to them for that particular kid based on not only the surgeon's preference, but the families and that of the NICU staff.
Yeah, I mean, I guess my only reaction to that, Dave, is that you probably are dropping off. Like it's again, I think it really actually exemplifies what I was saying earlier about how badly do you not want to shunt a child. I think that's the one end of the spectrum is that you sort of tap indefinitely and hope that a couple kids drop off the curve. I think the downside to that, though, is that you definitely are accepting that there probably is some subset who are not benefiting neurocognitively over the long term at the expense of not getting a shunt. And so I think the set point is somewhere in the middle. I think that, you probably are right that you could kind of tap kids until they're 4 kilograms and get a subset of kids who don't absolutely neurosurgically require a shunt. But I have a hard time believing that their neurocognitive outcomes are going to be optimized. I think they won't have a shunt, but they're likely prolonged ventricular distension because when you are tapping, you are distending their ventricles over time because it's not continuous drainage. I think that's sort of the extreme of the Elvis. That's like the third arm of the Elvis, right? The late, late, late. And so I'm just not sure. I understand what you're saying, but I think that might be sort of, to paraphrase what Peter said, throwing the baby out with the bathwater, which is like no shunt at all cost kind of deal. Anyway, that's my sort of reaction to that. Jenny, do you have any thoughts you want to share?
I would just add that I think the only way we're going to figure this out is looking at the long-term neurocognitive outcomes. I think about it like with the spina bifida kids where we're tolerating bigger and bigger ventricles over time, where kids, 20 years ago who would have automatically been shunted like immediately after birth are now going on and just having big heads. And some of the data for that is showing that there really isn't any difference in neurocognitive outcomes, and some of the studies are, but I think that's the only way we're going to really figure this out is like looking, 20 years down the line and seeing how these kids are doing.
Yeah, I think you're right. The challenge is constructing that study and not getting drop off, which is why the late drift data was so compelling because in Bristol they kept it they keep track of these kids forever. And so it does seem that there is some benefit to washing that stuff out or, reducing the ventricular distension. But you're right, like that would be the best study that could ever be constructed. I unfortunately, and maybe I'm being cynical, and Chiarelli, tell me if you think I am, but like I don't think we're ever going to see that study in the U.S. I think at best we might get 5-year data. I agree with you though that we need 20-year data, but I just don't realistically think that that's achievable in the U.S. and it would be very expensive. Am I being cynical?
No, I mean, I think that the way that the field is headed, ideally is going to have quite a few biologic treatments that are going to be into clinical trials sometime in the near future. I think that people are really better understanding the impact of inflammatory changes after bleeding. And so probably we won't see, I agree with you, we won't see drift in its existing form, but we're going to see a number of corollary studies that are going to be based on trying to reduce the inflammatory impact of blood, dissolving blood in some biochemical way that, functions to reduce the overall immune burden of the condition. And potentially through that, we'll have different outcomes measures that we'll be able to track. So fingers crossed.
And I guess the other piece to this, unfortunately, is that to get that 20-year data means to be waiting 20 more years to evolve our treatment on hydrocephalus.
Yes.
I just realized that as I was saying. I was like, all right, well, and it's going to take us 20 years to figure it out. But Austin, thank you. That was a great overview. Austin, do you have any parting thoughts for us as to how this has impacted your thought process about managing neonatal IVH? How are you, where do you find yourself in this milieu?
Um, yeah, so I did this topic because every time I got one of these consults, I didn't really know what to do. And now I realized I didn't know even more than I didn't know. So,
That's a good place to be. That means you're thinking about it, Austin. To be honest, I think that's a very mature assessment. I'm 20 plus years ahead of you here, and I feel the same way. You know. Anyway, thanks everybody. That was a great discussion, and thanks Austin for putting that together.
thank you.
Ruth, you have any parting thoughts for us? I guess so. All right, awesome. Take care, guys.